Everybody. As you know, this is the second webinar of a fourth lesson that we have together with Francesca Milano in the next month. Dr. Milano and I have developed a series of 4 webinars that are specifically designed for dental professionals who are interested in management of sleep-related breathing disorders. And our goal, as I told you in the previous webinar, is to provide you with all the basic knowledge and clinical tools that are needed to become familiar with this interesting topic, interesting and growing field, and to understand also how to successfully manage patients affected by snoring and obstructive sleep apnea. If I may, I would like to briefly recap the final part of our first webinar to provide a smooth and straightforward introduction to today's second webinar. As you know, and as I told you in the previous webinar, the diagnostic pathway for sleep deprivation and fatigue assessment passed through 3 different levels. The first one is to use validated questionnaires. Then the second one is the specific clinical examination of the patient, while the third one is the use of dedicated diagnostic tools to make a definitive diagnosis. Concerning the first one, we use validated questionnaires, and I will tell you that the 2 questionnaires that I suggest you to use, the first one is the Epworth Sleepiness Scale. It provides an indication of a person's level of daytime sleepiness, which may be related to sleep fragmentation caused by apneic events. As you can see here, you can see the difference between 2 hypnograms, that is a graphical representation of sleep architecture, one from a young individual with ideal sleep, and the other one below from an older adult with fragmented sleep. And the older individual spends less time in deep sleep, the one we call it N3, and as a result is more likely to experience daytime sleepiness and fatigue. A very similar pattern is also observed in patients suffering from obstructive sleep apnea, where repeated respiratory events fragment sleep and prevent the restoration of normal sleep architecture. And the second questionnaire that we use usually is the so-called Stop Bang questionnaire. It's a screening tool for OSAS. We use a quick and validated 8 questions, 8-item questionnaire, to identify individuals who are at risk for moderate to severe obstructive sleep apnea. The second step after the questionnaire is the clinical examination. And as you know, the clinical examination essentially is for us important to evaluate whether anatomical conditions are present that may contribute to upper airway collapse. So, for example, we look for obesity, because obesity is a major risk factor for OSA. We know, for example, the subject who has a BMI more than 30, the 40% of them suffer from OSAs, while patients who are severe obese patients with a BMI more than 40, the 90% of them suffer from OSA. So for sure, one of the things we do is to measure the BMI of the patient. One of the other things we do is we measure the neck circumference, that we should be less than 41 centimeter in a female patient and less than 43 in a male patient. Then the other clinical consideration we do is to evaluate for structural nasal abnormalities and also eventual inflammation of the paranasal sinuses. Because, for example, if we see a patient like this is a patient I saw last week with a skeletal class 2 malocclusion associated with the snoring and obstructive sleep apnea. The patient was highly motivated to improve facial aesthetic and therefore accepted our proposed combined orthodontical surgical treatment. And as you can see here from extraoral picture with lip closed and we smile, we can see that there is a second-class skeletal structure, but we deeply see also other characteristics of the patient. For example, if we focus on the patient anatomical features, it is easy to identify a significant nasal septal deviation, which almost certainly contributes to the patient snoring and obstructive sleep apnea. And if we see the radiographic examination, the sagittal midline slice from a CBCT of this same patient, we see that we have a reduced sagittal airway space at the hypopharyngeal level because of the retroposition of the mandible, and so the lingual lymphoid tissue, the soft palate, are going to collapse if the patient is going to sleep. And so this is the skeletal and aesthetic structure of the patient. And as you can see here, we can easily see with these slices of the tomography evaluation the presence of nasal obstruction that can for sure reduce the effectiveness of mandibular advancement device therapy. So all of these patients are analyzed, and before starting the orthodontic treatment, before doing surgery, we want always also that the otorhinolaryngologist can see the patient to see if there is a solution that can improve the result of the treatment. Then we see always the oropharynx, and we do the so-called Mallampati-Friedman evaluation that provides an indication of the amount of tongue tissue occupying the pharyngeal airway space. Another evaluation that we do is the so-called Brophy tonsil grading scale. The grade 4, for example, corresponds to tonsil that touch each other at the midline. So we know that the tonsil extend to the midline, the so-called kissing tonsil. And so we know that, of course, it is an important predisposition of degree of obstruction in this pharyngeal airway space. As you can see here, we have the intraoral view of the oropharynx in a patient of 14 years old before adenotonsillectomy and after adenotonsillectomy, before it has 24 of HI, so the apnea-hypopnea index, and then after the surgery the number is 3, so we solved the problem. But you have also to note the length of the uvula. This is a consequence of the repeated negative intrathoracic pressure that is generating during each apneic event, which exerts a downward traction on the upper airway soft tissue, resulting in uvular hypertrophy and elongation. So you can see which is the color of the mucosa, which is the dimension of the uvula before and after the surgery. Then another situation that we always check is the instrumental assessment at the end of this pathway, because when a definitive diagnosis is required, an overnight cardiorespiratory polygraphy should be performed. And as you can see here, when we have the limitation of the airway nasal airflow, when the apnea terminates, a marked snoring sound is typically observed, and it is accompanied by a reopening of the upper airway, an increase in oxygen saturation, and a rise in both respiratory and heart rates. So concerning this second meeting, we want to talk about the role of dentists in dental sleep medicine. So possible therapeutic options, advantages and limitations of orthodontic treatments, and so on. To summarize, snoring and obstructive sleep apnea are caused by posterior collapse of the pharyngeal soft tissue. As illustrated in this image, one common phenomenon that should always be considered is mouth opening during sleep. And I would like to start by discussing this important topic as it plays a key role in the pathophysiology of upper airway obstruction. Here you can see, as you watch this dynamic MRI, notice the complex interaction among the pharyngeal soft tissue during speech. So, when tongue is in resting position, the mouth is closed and the tongue always needs to touch the anterior part of the palate. This is absolutely important because what you have to know that when the mouth opens, the tongue loses contact with the palate and falls backward, reducing the pharyngeal airway space. And as we talk about literature, this is, for example, an interesting article that talks about the rule of intraoral negative pressure in airway stability during sleep. As you can see here, when we have the closed lips in oral rest position, we have a negative intraoral pressure. And the most important thing is that maintaining lip competence and negative intraoral pressure into the mouth is essential for stabilizing the soft palate and the tongue. When you open the mouth, this posture here disrupts this soft tissue balance and may compromise airway stability. This is another article that shows you that if you breathe through the nose with closed mouth, or if you breathe through the nose with open mouth, or if you breathe just only through the oral to the mouth, the airway velocity and static pressure is, for course, highest during oral breathing. And this is so important because also this article says that in the normal occlusion, so class 1 occlusion or class 2 division 2, these malocclusions are associated with the highest level of negative intraoral pressure, where when we have vertical discrepancies, so anterior open bite cases, or sagittal discrepancies like class 2 division 1 malocclusion, these situations are associated with slightly lower negative pressure values, and as a result, stabilization of the tongue against the hard palate becomes more difficult. And as you can see in this article, it's quite interesting. You see the pressure and reduced negative intraoral pressure are seen in open bite cases and class 2 division 1 malocclusion. And it compromises soft palate and respiratory tract stabilization. The negative intraoral pressure is fundamental to the stabilization of the soft palate and tongue, reducing neuromuscular activity for the permeability of the respiratory tract. For example, as you see here, the tongue repositioning maneuver that is made with this construction bite here provides physical stabilization of the tongue and the soft palate together. And this is quite good because it provides the nasal breathing. So the data of this article provide evidence that dynamic stabilization of the orofacial system with this device here, in conjunction with nocturnal wear of this oral shield, is beneficial for the reduction the symptoms in primary snorers with normal BMI. And we know that, for example, the mandible position is important, is compared of the way you are breathing during the night. For example, the study demonstrate that the jaws of patient with OSA are open more during sleep than the jaws of normal subject. And also in that situation, we know that all the patient who snores and make apneas during night tends to open the mouth. And another important things that we know from other articles like this one is that it is demonstrated that the amount and duration of mouth opening is significantly greater in supine position than in the sitting or lateral recumbent position. And this is so important from us because what we can do is giving to the patient also the opportunity of having the so-called positional therapy. Positional therapy belts, as you can see in this image here, are designed to prevent patients from sleeping in supine position, where upper airway soft tissue collapse makes snoring and obstructive apneas more likely. And we know also that upper airway resistance during sleep and the propensity of obstructive sleep apnea are significantly lower while we breathe through the nose rather than to the mouth. And this is a very important slide because, as you can see here, the upper airway resistance is low during wakefulness, whether breathing occurs through the nose or through the mouth. But however, it increases significantly during sleep, especially during mouth breathing. So if you during sleep breathe through the mouth and not through the nose, you have much higher value of upper airway resistance. And so what we know for sure is that maintaining lip competence and negative intraoral pressure is essential for stabilizing the soft palate and tongue, while open mouth posture disrupts this soft tissue balance. And so, as you can see here from this slide here, you can see that with this sleep endoscopy, we can see in this patient that we have an apnea event. So we have an anteroposterior collapse of the upper airway. This is the epiglottis, and this is the lymphatic tissue of the tongue base. This is the open situation when the patient is using the mandibular advancement device. But it is the same situation when the patient had his mandibular advancement device in the mouth, but it is opening the mouth. So with vertical opening, even if you have the mandibular advancement device in the mouth, you have a closure of the pharynx. And you can see here that from this review of the literature, all these articles says that the AHI value is very high if you're not using any device in the mouth. The value are better if you're using an oral appliance that is not controlling the mouth opening, but the best results you can have only when you're using the device in the mouth, and also the possibility of closing the arches with, for example, elastics. Because when the patient opens the jaws, you have a posterior and caudal displacement of the bone hyoid here. So the tongue and epiglottis move in a posterior direction, and you have a decrease in pharyngeal airway size. So the key point of this information is that when using a mandibular advancement device, it is essential to maintain the control of the mouth opening throughout the entire night. We also know this from a beautiful work that was published by Francesca Milano in the Journal of Dentistry Medicine, where they compared the two big group of patients. Both of the patients were apnoic patient, and both the groups were the device, mandibular advancement device that is called Somnodent. But the difference is in the second group, the patient also used intermaxillary elastics. And as you can see here, the responders with the elastics were 77% as compared to the 36% of the first group. So these results suggest that the increasing vertical dimension with elastics may enhance the therapeutic effectiveness of oral appliance therapy in positional oses. And as you can see here, we have the tomographic examination and the airway evaluation of the patient who is wearing a somnolent device. And it's so important that the patient has to move the mandible forward in the so-called counterclockwise rotation of the mandible. But it is so important that the patient use also intermaxillary vertical elastics during the night. And this is the design of the device. And we always ask for hooks just to use intermaxillary elastics during night. All these things can be provided with the sleep aligner from Smartee. As you can see here, we have hooked wings for sequential protrusion of the mandible, and this shape of the hooks is because we want the vertical control. Then we have buttons. That is an option that we can ask for our device for vertical elastics. And then we have occlusal pads for stabilize the vertical distraction of the patient. As you can see for this patient, this is the intraoral scan using the George gauge with 5 millimeter of vertical distraction. This is the Smartee simulation. And that's the clinical situation when we give the device to the patient. This is the sleep aligner in the starting position, the frontal view. And for me, the anterior vertical distraction is too high. And so from the lateral point of view, you can see that if you have an excessive vertical distraction, it decreases the effectiveness of the oral appliances by causing clockwise mandibular rotation. As demonstrated in the literature, as I told you before, this results in a reduction of pharyngeal airway space. And that's the reason why we asked for a reduction in the vertical distraction. As you can see here, how big is the difference with the same sagittal protrusion but with different vertical distraction. On the left you have 5 millimeter of vertical distraction, on the right just 2 millimeter of vertical distraction. How we can manage a new case, a new sleep aligner case? We always use a George gauge device to register the construction bite. Dr. Milano will explain deeply you in the next webinar and in the Smartee symposium that we will have in Spain in September. But anyway, what we suggest to you is to use the adult fork with 2 millimeter of vertical distraction in the anterior notch. That gives you the opportunity of having the little vertical distraction as you can. That can be quite effectiveness. As you can see here, we have another case with 5 millimeter of vertical distraction. This is the device in place from the Smartee digital program. And as you can see here, for me, also that situation is too high vertical distraction. So when I find this kind of situation, before accepting the case, I always ask to the technician to have a new case titration design. We asked before less 1.5 millimeter of vertical distraction, and then we accepted less 2 millimeter of vertical distraction from the starting position. And in that situation here, as you can see here, we have a very thin distraction, a very comfortable device, and it's very effective for the patient. This is because as the mandible moves downward, it also shifts posteriorly, reducing the pharyngeal airway space. And that's the reason why we always try to have the smallest vertical distraction as we can. So go on in this topic, I want to discuss with you the opportunity of having the multi-level obstruction. That means that we need to consider different therapeutic options for patients who suffer from snoring and for sleep apnea. As you can see here, the CPAP treatment and mandibular advancement device treatment are highly effective treatments. But unfortunately, patient adherence may be limited. In contrast, surgery is a one-time treatment that doesn't depend on patient compliance, although its effectiveness is generally more limited. Talking about surgery, it can for sure improve airway, improve life. The surgery can be done at different levels from the nose to the tongue. Starting from the nose, the surgery can help to treat nasal obstruction. It is absolutely a key rule in upper airway patency, and it is essential for effective surgery and dose management. What I want to tell you is that the impact of surgery can be very important for us. And concerning the nose, we know from the literature that if we have a high nasal resistance, the improvement of our treatment can be difficult. So the clinical implication of this is that to assess nasal airway patency before mud therapy is crucial. And so we need to identify and treat nasal obstruction like septal deviation, turbinate hypertrophy, rhinitis, and polyps. Because if we promote nasal breathing and mouth closure during sleep, our orthodontic treatment can be much more effective. And this is something that we know from the literature. For example, the clinical efficacy without oral appliances and with oral appliances that can give the opportunity for the patient to breathe normally is mandatory. So if the patient has some obstruction of upper airway, it can be useful to use device like this one. For example, this is an herbs-like mandibular advancement device, and as you can see here, it has an anterior channel to guarantee oral breathing if the patient has some problem to breathe through the nose. And this kind of opportunity is possible in many devices. For example, this is another device that is made in nylon. And so the oral surgery can be very effective for us in many situations. For example, in this one, when you can have an external valve collapse or you can have an internal nose collapse. And in that situation, to make surgery before can be very interesting for us to improve the quality of our treatment. Also in that situation, we have a presence of a deviated, as you can see, nasal septum with a bony spur, as you can see here, obstructing the right nasal cavity. And so in all of our patients, when we do the clinical examination, we look into the nose to see if there is an hypertrophy, for example, here of the lower turbinates, or we see if there is the deviation of the septum. And also if we look at the radiographic examination, we pay a lot of attention of the nasal cavity. For example, in that situation, we have a deviation of the septum, mainly due to an anatomical abnormalities here of the middle turbinates that is called concabulosa. That is a pneumatized turbinates that is going during years to deviate the nasal septum, as you can see here. So one the opportunity in that situation is to ask to the surgeon, for example, to make an inferior turbinatectomy, as you can see here with the braided. That is a very good surgical item that is going to restore nasal patency that is going to improve the quality of life, and mainly it enhances response to other therapy, for example, CPAP therapy of mandibular advancement device therapy. There can be different way of doing surgical treatment of turbinate hypertrophy, and the first line is medical therapy with drugs. Another level of surgery can be the palate, because we know, for example, that many years ago, one of the most used surgical technique was the so-called uvulopalato-pharyngoplastic. And this technique was, the aims of this technique was to enlarge the oropharyngeal airway by removing the excess tissue of the uvula, the soft palate, and sometimes also the tonsillar pillars. But as you can see here, this is the clinical situation after the surgery, after some months. And following resective surgery, uvulopalato-pharyngoplasty resulted in a shortened but stiffened soft palate, which provided limited long-term benefits. And as you can see here from this article, the long-term efficacy of this surgical technique shows that you have an AHI reduction in a short-term postoperatory time, but later on the AHI values tends to grow. And so what we know that is this technique remain effective in long term, but its efficacy significantly declines over time. And that's the reason why now there are different surgical techniques. For example, the lateral pharyngoplastic, or for example, the barbed repositioning pharyngoplastic. In this surgery, they are used these barbs anchor themselves automatically, securely holding the wound edge together without the need to tie surgical knots. And as you can see here, the lateral pharyngoplastic works like the curtains of the theater that are opened, and it's going to work, giving the opportunity of having a laterally open of the pharynx, improving the airflow. And if we see from the literature the comparison of the lateral pharyngoplastic as compared to the uvulopalato-pharyngoplastic, we know that it provides superior clinical, polysomnographic, and anatomical outcomes as compared to the conventional surgery. Another kind of surgery can be done in the hypopharynx region, so in the tongue. For example, one of the most used surgery of the tongue is the so-called transoral robotic surgery, TORS. And the TORS enables precise resection of obstructive tissue throughout a transoral approach using the robot technology. It is a safe and effective option with durable result and low morbidity. Another very interesting surgery is the so-called hypoglossal nerve stimulator. A high effective but very expensive technology, hypoglossal nerve stimulation. Implanted pulse generator detects inspiration, so the system detects the expansion of the rib cage during inspiration and delivers electrical stimulation to the hypoglossal nerve, causing the tongue to move forward and keeping the upper airway open. I want to show you an interesting video from the Mayo Clinic Hospital. I divided the video in 3 different slides just to explain you how it works. As you can see here, The hypoglossal nerve, here you can see here, is surgically exposed, and then after the hypoglossal nerve is surgically exposed, it is isolated and wrapped with a stimulating cuff electrode. This is the cuff electrode that is wrapped around the nerve. Here we are. Then the second stage of this interesting surgery is the one who placed the machine in the under the skin and in the thorax. It is anchored with a suture and then is placed under the skin. And then the third part here, the hypoglossal nerve stimulation delivers, as you can see here, mild electrical impulses to the hypoglossal nerve during inspiration. So this activates the genioglossus, as you can see here, and other tongue protrusor muscles, moving the tongue forward, I will show you again, and preventing upper airway collapse during sleep. So as a result, the airway remains open, reducing obstructive apneas and snoring. As you can see here, the tongue is moved forward during the inspiration. Another important surgery that can be done in patients with severe OSAS is the maxillofacial surgery. I'm showing you this patient is a 31-year-old male patient. He came to our office because he reports being a snorer, and he reported also apneas during sleep, and he had also an excessive daytime sleepiness. He's a smoker. He has a neck circumference of 39, that is not bad, and he has a good BMI. He already underwent septoplasty to correct ventilatory deficit. We made the self-assessment questionnaires, the Epworth and the Stop Bang, and both these questionnaires said us that he has an excessive daytime sleepiness, and also that it has a high risk of OSAS. But mainly we made the polygraphic examination, and the polygraphic examination of the patient before starting the treatment says that he has a 36 value of AHI. You have to remember that this value more than 30 it means that is a severe case, and we also know from the polysomnographic exams that he has a big component of supine AHI value, because it is much more than non-supine position. And so this patient have a very severe OSAS. It is a very severe OSAS case. So this is the situation before surgery. He was highly motivated by the prospect of improving his facial appearance. And so together with the patient, we decided to proceed with a combined orthodontic surgical treatment using clear aligners for pre-surgical orthodontic preparation. As you can see here, that's the situation just before surgery, when we have aligned teeth and prepared the jaws with aligners. And this is the radiographic examination. Then the patient presented with pharyngeal airway narrowing secondary to mandibular retrognaxia. This is the reconstruction of the soft tissue. And this is the digital surgery plan that we made with the surgery, with the counterclockwise rotation of both the jaws. And that's the situation before and after the surgery. And as you can see, the CBCT analysis demonstrated a marked increase in upper airway volume following orthodontic surgery compared with the preoperative condition. But the most important thing is that the patient showed a remarkable reduction in the number of apneic events, although he also gained weight. But we started from 36 and now we are less than 5. So with the orthodontic surgery, we were able to improve the facial aesthetic of the patient, and mainly we solved the problem of the apnea, that is the clinical situation just 1 month after surgery. And as you can see here, we have just to little improve the occlusion with the refinement phase, but the improvement of the facial appearance was absolutely good, and the patient was very happy about that. Then to conclude, I want to show you which are the so-called conservative therapies that can be done by the physician for snorers and those aspiration. These are non-invasive solution, CPAP treatment, positional treatment, and mud treatment. The CPAP treatment we already talked about in the first webinar, but it is the so-called continuous positive airway pressure machine. The pressure required varies from 4 to 16, 17 centimeters of water, but of course the tolerance decreases as pressure increases. And unfortunately, even if it is an incredible device, because it is the gold standard therapy for us patients, unfortunately, it has been estimated that almost half of patients are non-adherent. And non-adherent is defined as means of less than 4 hours of use per night. And so it is a big problem for the pneumologist who want to treat this patient with this device. And as you can see here, the effects of continuous positive air pressure therapy withdrawal always in patients with obstructive sleep apnea when they stop to use this device. As you can see here, this line here is showing that the AHI values are very low if the patient is using the CPAP, but when it withdrawal this device, immediately the level of apnea event are immediately very high. So it's mandatory that the patient needs to use every night for all the night this device, otherwise it doesn't use. The problem that the difficulties that the patient has during this treatment and the barrier factors are the difficulty getting used to the device, the dry mouth, the sense of anxiety, the headache, the noise of the machine, the discomfort, and also the problem that is concerning the fact that it's not a nice device when you sleep with somebody in closer to you. And when we compare the efficacy of the CPAP treatment as compared to the MUD treatment, we know for sure that the polysomnographic efficacy is better. The symptom control, the health benefits are quite similar, but the MUD treatment is much, much better as compared to the adherence, the tolerance, the patient and partner acceptance, and the convenience. There is another therapy that is so-called the behavioral therapy. That means that the patient needs to eliminate or reduce the risk factor. For example, it needs to avoid sedative medication, or he has to stop harmful habits. We know that one of the important things is to reduce the weight, and now we have also some interesting drugs therapy. For example, the tirzepatide is the first FDA approved drug for obstructive sleep apnea, it works, and it can be in the future an important medical therapy that we can combine with the MAD device, for example. And for sure, there are also other very interesting studies that are going to be published in the next month concerning the drugs therapy for OSAS patient. Then, as I told you before, there is the so-called positional therapy. Positional therapy employs belts or other devices to discourage supine sleep position, thereby reducing the frequency of obstructive sleep apnea events in patients with positional OSA. For example, we can also use this kind of belts. It continuously monitors patient position using an internal accelerometer. And when the patient rolls onto the supine position, this device delivers gentle vibration stimuli that prompt the patient to change position without fully awakenings. And this device is quite effective in patient who has a main positional OSAS. And then at the end, I just want to give you some little information about the mandibular advancement device therapy that will be deeply discussed by Francesca Milano in the next webinar. But these are custom oral appliance design therapy that advance the lower jaw forward and it helps to continue maintain the airway open during sleep. These devices are very effective. They can have different design, so there is no one advancement design that fits all for management of sleep apnea. We, for example, know that the choice of the right device must consider many factors. And we studied the design of different devices and we made publication about that. For example, showing with FEM analysis which can be the unwanted movement of the teeth during years when we are using the MAD device. And we know, for example, that a central connection device could affect mostly the anterior teeth, while the lateral connection provides a more uniform distribution of the load on teeth. So just to conclude, what I want you to tell is that when you will start to treat your patient with the MAD device, you should consider absolutely to use the sleep aligner device for many reasons. One reason is, for example, that this patient is the typical OSAS patient that can develop some, unfortunately, bad position of the teeth during years. The edge-to-edge patient like this one, you can see here that we have a very little overjet, and that's the intraoral situation before treatment. It was a severe OSAS patient. It was treated by me 5 years ago with this kind of device. It's called the Somnolent Avant. As you can see here, these are the hooks for the vertical elastics. And it using this kind of device that is giving to the patient the opportunity of pushing the mandible forward. He was so happy of the treatment, he solved all his problem concerning the snoring and apnea, and I didn't see the patient for more than 5 years. And it came in my office 2 months ago, and as you can see here, after more than 5 years of treatment, there have been a big changing of the occlusion with an open bite, with a cross bite in the anterior area, and with this kind of situation from the lateral situation, lateral occlusion. What you should know is that the patient is absolutely happy of the treatment. He's not interested in the changing of the malocclusion because it is able to sleep good and he solved all of these health problems. But what I I would like to do now, and I will sure do in all of my patients of this situation, is to treat it with the third generation of mandibular advancement device. Because the third generation mats are incredibly thin, extremely comfortable, and easy to manage for both the clinical and the patient. And most important thing is that the sleep aligner treatment can give you the opportunity using the Plus device also to combine sleep medicine and orthodontics in a single system. Because at night, the lateral wing configuration is used to manage sleep disordered breathing, whereas during the day, the simple aligner functions as a standard orthodontic aligner to progressively align the dentition. And so in this kind of patient, for example, as you can see here, you can use the daily aligners to well aligner the misaligned frontal teeth, but in the edge-to-edge patient or third-class patient, you can improve the proclination of the upper incisor and you can incline lingually the lower incisor to provide the side effect of the MADS that can happen during years. So I just want to finish with this slide because for sure in the next two webinars and in the Smartee Symposium in September, we will go deeply in how to treat this patient from a clinical point of view. So thank you very much for your kind attention. And Sharon, I will say that if somebody has some questions, I'm here, or they can write to you and then I can answer in the next weeks.